going to straddle a few aspects, mainly that the three roles of the doctor really, that of the chief medical officer, the team physician, and the matchday doctor. And as you heard, Dr. Harcourt will be talking about the last one, so I'll skim over that. But the chief medical officer has legal obligations, he has administrative oversight, and oversight over management of all teams. A team doctor, on the other hand, must oversee the medical support staff, manage medical protocols, and respond to emergencies. And the matchday doctor looks after the match itself. So one slide on the CMO, because the responsibilities are before a tournament and after a tournament, ensuring that there's medical screening. And not only that there's medical screening, but there's adequate transfer of data to relevant people, so that you don't find out that somebody's on tour with a medical problem or an injury and they're not aware of it. They're responsible for medical supplies, in terms of making sure that the organization has it. I put up standing orders because every country has different legal structures, but by and large, in common law, all responsibility goes to the CMO. So when I have a physiotherapist traveling, he's working under standing orders of the CMO. If he's giving medications, he's giving it, or he or she is giving it on behalf of the CMO, et cetera, et cetera. And of course, if somebody's going to get sued, unfortunately, it's going to be the CMO as well. So you've got to make sure that the legal standings of your country and the country you're going into are looked after. And then the CMO's responsibilities for medical plans, both for competitions, tours, et cetera, et cetera. Selection of appropriate medical staff, not appropriate medical friends. You've got to make sure you've got the right man for the right job. I keep saying man, please excuse me, the right person for the right job. So as far as the team physician is concerned, I think by and large it's now understood that that person should be a sports medicine specialist. Gone are the days when you had people with interest in sports medicine. This is a full-fledged specialty, and clearly they add a lot more than just carrying an orthopedic surgeon who happens to know a bit of sports medicine, or a general practitioner whose uncle is the president. I'm not referring to anybody in specific. There are pre-tour responsibilities, medical screen and medical records that I mentioned already, to ensure that that's all in place and everybody's aware of it, that you're aware of what the injuries are that you're carrying with you, that you've got medications for all your players, that the medical bag is in place. And I found it very useful to do this in conjunction with the physiotherapists, because, boy, they carry a lot of stuff, so to load them with a bit more is sometimes very easy. When actually covering the match, one thing that's very important is to make sure that you're positioned in a place that you can see everything. And I'm going to share a personal experience with you in a bit to exemplify that. But you must position yourself properly to know what's happening. And you must have under your wings proper protocols from before. Who is responsible for payments? Where is the hospital that's designated? Who are the specialists? That's supposed to come in the medical plan, but you still have to go over it again and again. I've had, way back, 20 years ago, 25 years ago, players stuck in an emergency room because nobody knew who was going to pay for the scan or pay for the treatment or whatever. That's inexcusable. It may sound simple to get somebody into a hospital, but it takes a lot of planning. This is one of my guys in Pakistan last year, but to get there took a lot of planning. To get to the hospital, to get in the hospital, and to get people out of the hospital required a lot of security. Now, we were afforded presidential status security, which was very, very strict. But when the person got injured, I'd visited the hospital the day before. When the person got ill, they suddenly told me I have to go to the military hospital, and I absolutely refused. I said that we have protocols in place, and unless my board tells me to change, I'm not changing. And so a whole lot of drama that you can see there took place. But the point is, these protocols have to be adhered to, and nobody should come in the end, because you know what comes after. You know, if you do this, you know where you're going to get the test done, you're going to know where the medications are, et cetera, et cetera. So as far as the team physician is concerned, when dealing with injuries, they must follow clinical principles. History and examination still supersedes MRIs and ultrasounds. And I find that that's a lost art now. Adequate investigations, and I said, be they ultrasound or MRI, and I put that in purpose because the ultrasound is very good for the majority of things. You don't have to run to an MRI for everything. Yet, team physios are propagating this concept. Unqualified or non-sport specialists are propagating this concept. And so every player feels that if they don't get an MRI, they're not being treated properly. Yes, we do overuse the MRI sometimes, because I use it for prognostication. If I'm in a tour, I may have to do an MRI to see whether this person can stay on tour or not. But honestly, a clinical examination and history should give you the diagnosis. There need to be clear-cut protocols that if you are going for scans or for hospitalization, who's going to go? Is it going to be the physio? Is it going to be the doctor? Is it going to be the manager? And once you've finished with the management, you've got a diagnosis, there has to be proper discussion with everybody. The physio, the player, and the coach have to be involved because everybody then has their bit to come to the final management decision. It's not the doctor's decision, it's a team decision. On the field, you have to be cognizant that the physiotherapist is usually the first responder. There's a whole protocol of hand signals that the ICC has standardized and is practiced before every match. So before every match, the match day medical team and the team's medical team get together and go through this dance, which is very important because in spite of it, I've been faced with many situations where when the actual time comes, people forget the signals altogether. In an emergency, in a real emergency, all hands on deck, so you don't have to wait for the physio to call you and so on, but clearly there has to be understanding as to who's going to take charge. And management of head knocks. I believe that if there's a physician present, they should take responsibility. I'm finding that more and more physios in particular are getting pressured by their team management and the team owners of franchises to either underreport concussions or turn a blind eye to them. And we might have to go the route of rugby one day where you need independent doctors to verify this. I'll point out that there's practiced in this World Cup and moving forward, there's even a time guideline for on-field management, 4 minutes, after which you have to negotiate the rest if you need it. So I'm just going to share with you one example that took place many years ago, but it's for a point for discussion when we get early. I had just arrived for this test match against Australia, literally came off the plane from an ICC meeting, got there, and I was sitting in the dressing room, literally where this picture is being taken from, discussing what had happened in the match. As you can see, there's no sight of the pitch where I'm sitting. And within 5 minutes, this happened.
Hit him on the back of the helmet, he's down.
Now you notice that he's out cold. First person to get him is the bowler.
Right on the back of the helmet. Lee is down there, the first man.
After 56 seconds, the first responders are actually the Australian team physio and doctor because we were inside not noticing what was going on because it's debriefing. And then when I actually found out what happened, it took me 9.58 seconds to get to the middle, like every Jamaican runs. And we took him off. Now by the time I got to him, he had not only regained consciousness, I had no idea of what had actually happened. If you notice, we're 155 runs behind. Chandapal was on 87, and I couldn't drag him off with wild horses. But not recognizing the gravity of what had happened, he continued to bat. He made his century. But when I look back at the video, you realize that had I known what had happened, there's no way it would have continued. So now there are provisions, of course, for even video analysis and so on to take place to determine the concussion. But I brought that up because that was a judgment decision that you've got to make at the time with what you've got in hand. But when you look back, you say, how did I let that happen? Point for discussion. So the team doctors must manage injuries on merit. You've got to decide whether the person will continue in the game, as I pointed out there, whether they'll continue in the series or continue in the season. We had a discussion yesterday on ankle impingement. And we spoke about injecting the person versus doing surgery. And sometimes you may inject the person because they're in the middle of the season. They say, okay, you need surgery, but we'll do it at the end of the season. Let's see if we can get you through. Consider the state of the competition and tour, as I just said. Be mindful of future engagements and potential for worsening of the injuries if you don't treat it properly right now. Scarring and chronicity taking place. But in the end, the idiom of all doctors, do no harm. I'm going to skip this part on the match day doctor because that's going to be done by Dr. Harcourt. But in the end, one message again, do no harm. Thank you very much.